Welcome back to the deep dive. Today, we're really getting into something important, using those revision notes you sent over.
Yeah, good stuff in there.
Definitely. Our mission today is to unpack herpes simplex encephalitis, HSC, based on these notes, make it super clear, high yield for your revision.
Absolutely. We want to turn these notes into something, really memorable.
Because HSC is, well, it's crucial to understand, right?
Couldn't agree more. It's rare, but missing it, that's serious. So let's get started.
Okay, first things first, the definition. Based on the notes, what exactly is HSC?
Right. So at its heart, it's a viral infection of the brain. Causes inflammation of the actual brain tissue.
And it's serious but rare, you said.
Yeah, rare but serious. And the main virus involved, according to the notes.
Underwhelmingly, herpes simplex virus type 1, HSV1.
That's the one. It's actually the most common cause of infectious encephalitis, the really severe kind.
Gotcha. And the notes made a distinction, didn't they? Encephalitis versus meningoencephalitis.
Yes, good point. Encephalitis is the brain tissue inflammation. Meningoencephalitis means the brain and the meninges, those protective layers around it, are inflamed. So slightly different focus.
Okay, brain substance versus brain substance plus coverings. Makes sense. So moving on to the etiology, the cause. We know HSV1 is the big one for adults and kids.
Yeah, globally, that's the main player.
But the notes mentioned HSV2 as well.
They did. HSV2 is primarily the cause in newborns, neonatal HSC. They usually get it during delivery.
Huh?
It can cause HSC in adults, but it's much, much rarer than HSV1 in that group.
And how does the HSV1 actually, cause the problem? Is it always a new infection?
Not usually, no. Often it's a reactivation. Someone might have had cold sores years ago. The virus lies dormant.
And then it wakes up.
Exactly.
Yeah.
And it travels along the nerve pathways to the brain. The notes also touch on other herpes viruses like CMV, cytomegalovirus,
Right.
rarer causes, but something to keep in mind, particularly if someone's immunocompromised.
That brings us neatly to the risk factors. Who's more likely to get this?
This is really key clinically. Your notes lay it out nicely. Big one is being immunocompromised.
Like HIV/AIDS, or maybe an organ transplant recipient?
Precisely. Their immune system can't keep the latent virus in check as effectively.
Makes sense. What else?
A history of herpes infections, cold sores, genital herpes is listed. Age is another factor.
Oh, which ages?
The notes mention peaks in incidence in childhood and also in older adults. And there's a suggestion maybe of some genetic susceptibility playing a role too.
So thinking about these factors helps you know when to really consider HSE.
Absolutely. It raises your index of suspicion for the right patient.
Okay, high yield stuff for sure.
Yeah.
Let's dig into the pathophysiology. How does the virus actually damage the brain?
So HSV1 gets into the central nervous system. Once there, it starts causing inflammation, but also direct damage to the neurons, the brain cells themselves.
And it follows specific routes.
Yeah, it travels along those neuronal pathways, which is why it often hits specific parts of the brain more than others.
And the body's own response makes things worse.
Kind of a double-edged sword, unfortunately. The immune system rushes in to fight the virus, but that inflammatory response itself causes further damage. It's complex.
And your notes really hammer home that HSV1 is behind most adult cases.
Yeah, about 95%, the notes say. And characteristically hitting the medial temporal lobes and the inferior sort of bottom parts of the frontal lobe.
Temporal and frontal lobes.
Yeah.
Okay. Knowing that helps predict symptoms. But wait, before symptoms, the differential diagnosis. This sounds tricky. What else looks like HSE?
Hugely important step, because the early symptoms can be quite vague. You have to think broadly. Your notes give a great list of mimics.
I think other infections.
Definitely other viral infections, but also non-infectious things like autoimmune encephalitis.
Where the body attacks itself, basically.
Exactly. That's a big category. Then there's meningitis inflammation of the coverings, not the brain itself, though they can look similar early on.
Okay.
Brain abscesses, pockets of pus. Cerebral vasculitis, inflammation of the brain's blood vessels. Other CNS disorders generally.
Wow, quite a list. The notes even mention specific conditions like Behçet's disease, lupus.
Yes, SLE, stroke, MS, even syphilis, brain tumors, space-occupying lesions, leukemia, lymphoma.
So someone comes in confused, feverish. It could be a lot of things.
It really could. You need a systematic approach to rule these out. Treatment depends massively on the correct diagnosis.
No kidding. Okay, challenging differential.
Mm-hmm.
How common is HSE? Let's look at the epidemiology from your notes, especially the UK figures.
Well, the good news is it's rare. Estimated UK incidence is about 1 in 250,000 to maybe 1 in 500,000 people per year.
So not many cases annually.
Not many. It can affect any age, but again, those peaks in childhood and older adults are noted.
How does that compare to, say, encephalitis in general?
Overall, acute encephalitis is more common. Your notes quote figures for England around 5 to maybe 8 or 9 cases per 100,000 per year.
Okay, so HSE is a rarer subset of that.
Exactly, but a particularly severe subset. The notes stress that infections are often most severe in kids and the elderly. Neonatal HSE is devastating, but severe cases happen in adults too.
There was also a mention of post-infectious encephalitis.
Yeah, complicating childhood illnesses like measles or chickenpox sometimes. Different mechanism, usually autoimmune after the infection.
Got it. So HSE, rare, but really serious, especially at the age extremes. That drives home why we need to spot it. Which takes us to clinical features. What does it actually look like?
Right, connecting pathophysiology to presentation. Because it hits the brain, especially temporal frontal lobes, you get a mix. Fever, headache, common infection signs. But then the neurological stuff kicks in.
Okay.
Altered mental status is key. Confusion, personality changes, difficulty thinking. Seizures are very common, mentioned prominently in your notes.
Okay, seizures. What else?
Focal neurological deficits, maybe weakness down one side or sensory loss. Behavioral changes can be quite striking, and it usually comes on fast, rapid onset.
The notes mentioned it can start looking like something else.
Yeah, sometimes it might initially mimic meningitis fever, headache, maybe vomiting, stiff neck, but then progresses often rapidly to more severe things. Deeper confusion or coma, more seizures, signs of raised intracranial pressure, those psychiatric symptoms. It's not always a neat package. Could start like flu, could be just a headache, then boom.
And the notes mentioned potential long-term problems even here.
Yes, things like ongoing epilepsy, persistent focal signs, cognitive difficulties. Important to remember the potential for long-term impact.
And the neonatal version sounds completely different again.
Very different and incredibly severe. Neonatal HSE, usually HSV2, think lethargy, irritability, not feeding well, tremors, seizures, a bulging soft spot of the fontanelle.
That sounds awful.
It is, and if it spread systemically, shock, jaundice, bleeding issues, sometimes a characteristic vesicular rash. Prognosis is very poor, high mortality, a distinct entity.
That difference between adult child and neonatal is vital for revision. Okay, we suspect it. How do we prove it? Investigations.
You need a combination approach, really. Clinical picture plus tests to confirm and rule out those differentials we talked about.
First up, CSF analysis. Lumbar puncture.
Essential. Your notes say you typically find lymphocytosis, more lymphocytes, a type of white blood cell and raised protein. Tells you something inflammatory or infectious is happening in the CNS.
And brain imaging.
MRI is definitely preferred over CT, according to the notes. It's much better at picking up those early characteristic changes in the medial, temporal, and inferior frontal lobes.
MRI is more sensitive.
Yeah.
But the absolute confirmation.
PCR on the CSF polymerase chain reaction, looking for the actual HSV DNA in the spinal fluid, that's crucial.
For HSV 1 and 2.
Yes, and the notes rightly say you should often test for VZV, chickenpox shingles virus, and enteroviruses too, covering other bases.
What about EEG? Brainwaves.
Also useful. Notes mention it. Often shows abnormalities like diffuse slowing, maybe periodic discharges, can be helpful very early on, sometimes even before the MRI shows clear changes. Reflects brain dysfunction.
Right. Any other test?
Standard blood tests, of course. Full blood count, blood cultures, renal function, liver function, helps rule out other systemic causes or sepsis.
So CSF inflammation markers, MRI changes, and crucially, HSV PCR in the CSF. That's the diagnostic trifecta, more or less.
That's a good way to put it. Helps nail the diagnosis and exclude the mimics.
Diagnosis confirmed or strongly suspected.
Yeah.
Management, what's the absolute priority?
Speed. Your notes scream this, and rightly so. Prompt treatment is everything. Immediate. Urgent.
And the core treatment is?
Intravenous acyclovir. Specific antiviral medication. Needs urgent hospital admission to get it started IV. You don't wait for all the results if you suspect it. Treat first.
Okay, treat empirically. And supportive care.
Hugely important. Managing seizures if they happen, keeping fluids balanced carefully because of brain swelling, risk monitoring neurology closely. Anticonvulsants, sometimes sedation might be needed.
Notes mention possibly starting antibiotics too.
Yes, often initially you might give broad-spectrum IV antibiotics just in case it's bacterial meningitis while waiting for CSF results to clarify.
But the key for HSE itself is the acyclovir.
Absolutely. Timely acyclovir is what improves the prognosis significantly.
What about steroids?
The notes say their role is uncertain in HSE. Unlike some other brain inflammations, the evidence isn't clear-cut according to this source.
And for really severe cases.
Intensive care might be needed, ventilation, managing brain swelling aggressively, maybe broad-spectrum antibiotics if there's concern about secondary bacterial infection.
The notes mentioned amphotericin.
Yes, but they clarified that's for a different, very rare cause, primary amoebic meningoencephalitis, not standard for HSE. Seems like it was just listed for context of severe CNS infection treatments.
Got it. So core message, a cyclover, ASAP, hospital, supportive care. What about the prognosis? How do people do?
It really hinges on that early diagnosis and treatment. Starting a cyclover quickly is paramount. Without treatment, your notes give stark figures. Mortality around 80%.
80%, wow.
Or maybe 70% within a week or two. It's incredibly lethal if missed or delayed.
That really drives home the urgency.
Oh.
And with treatment.
Much better, but still serious. Mortality drops to somewhere between 10 and 20%. Your notes mention 19% specifically. Still high, reflecting how nasty this condition is. Encephalitis generally carries high morbidity and mortality.
And survivors. Do they get back to normal?
Often not completely, unfortunately. Many are left with long-term problems, residual physical deficits, or neuropsychological issues. Long-term management is often needed.
Are there factors that predict a worse outcome even with treatment?
Yes, the notes list some. Older age, being immunocompromised, being in a coma, needing a ventilator, or having acute thrombocytopenia, low platelets. These suggest a tougher course.
Which leads us straight into complications. What long-term issues are we talking about?
It's quite a list in your notes, highlighting the lasting damage. Persistent neurological deficits, weakness, sensory issues. Some people experience recurrent encephalitis flares later on.
Wow, recurrent.
Yeah. Seizures can become a chronic problem, epilepsy. Memory problems are very common given the temporal lobe involvement. Behavioral changes, too, linked to frontal lobe damage.
That sounds life-altering.
It really can be. Neuropsychiatric impairments affecting personality, ability to function socially or at work. And then the physical side. Balance problems, poor coordination, dexterity issues, problems with speech or swallowing can lead to significant dependency.
So surviving is just the first hurdle for many.
Absolutely. The
Yeah.
long-term sequelae can be profound.
Okay. We've really covered the ground here following your notes.
Mhm.
What HSE is, the causes, risks, the mechanism differentials, how common it is, the symptoms, including that separate neonatal picture, the tests, the crucial management, and the outcomes and complications. Thinking about it in this structured way.
Yeah.
Definition, cause, pathophysiology, features, investigations, management, prognosis. That's actually a great revision strategy in itself, isn't it? Following that logical flow helps cement the information.
Definitely. It builds a framework in your mind, makes recall much easier under pressure, connecting the why it happens to what you see and how you treat it.
Right. Well, that brings us to the end of this deep dive based on your notes. Just one final thought to leave you with. Considering how significant those long-term problems can be, even when treatment is given promptly, what does that really tell us about the immense importance of that very first suspicion, that rapid assessment and action in suspected HSE?
Something important to reflect on, for sure. The window for optimal outcome is narrow.
Indeed. Well, thank you again for sharing your notes. They provided a fantastic basis for this discussion. Keep going through this material. Keep making those connections.
And if you're looking for more resources for your MSRA preparation, do check out passmsra.com.
Loads of great stuff there. And also, don't forget about freemsra.com for, well, free resources.
Always helpful. Thanks for tuning into this deep dive.
We'll catch you on the next one.